Our next speaker is Dean Mikami on endoscopic treatment of weight loss.
I just want to thank the chairs, Dr. Thaler and Dr. Youngman, for putting on a fine program. My talk is going to be on endoluminal treatment of morbid obesity, and hopefully we'll get the slide started here. PC.
Can we have the presentation?
Okay. Oh, that's the talk for this afternoon. Thank you very much. Okay, so my topic today is going to be the endoscopic treatment for weight loss. Here are my disclosures. I will not have any conflicts with the products I'll be talking about today. So when we talk about obesity and type 2 diabetes, if you look at this chart, and I think this is a very telltale chart, here in America, when we're overweight, we usually have diabetes. In America or in the Middle East. But when you look to the left of the chart, in India, Japan, Korea, and China, these patients who have type 2 diabetes are not really associated with morbid obesity. But we know that when we do a weight loss operation, our patients' type 2 diabetes improves dramatically prior to them losing a lot of weight. So the current bariatric operations that we do today, the Roux-en-Y gastric bypass, adjustable gastric banding, the duodenal switch, and the sleeve gastrectomy are all very good operations. But what we want to mimic with these operations is an endoluminal approach to achieve this type of configuration. So what I will be talking today about is the endoluminal malabsorptive or space-occupying devices, the intragastric balloons, the butterfly device, the full sense, the ValenTx device, and for the endoluminal restrictive devices, the trans-oral gastroplasty or TOGA, the endoluminal vertical gastroplasty or endostinch, and the trim trial. And I apologize for using the trade names, but there's really no other way to actually talk about these devices without using their names. So when we talk about gastric volume displacing weight loss devices or the intragastric balloons, what these devices do is they delay the gastric emptying, they have a mechanical volume reduction, they change the hormonal structure of the stomach by increasing CCK, which is associated with appetite suppressant, and the distension of the stomach stimulates the gastric stretch receptors, which may make patients feel full. This is actually a slide of all the balloons that have been used in the past and that are used now throughout the world. Unfortunately, there are no FDA-approved intragastric balloons in America. But if you have a chance to go to an international meeting and walk around the exhibits, you'll see the bib, the heliosphere, the endogas type devices around. So let's talk about the Garren-Edwards gastric bubble. I think this is a very important device in the history of surgery. It was basically introduced back in 1988 with more than 250,000 devices implanted in patients without lack of a controlled study. But between 1987 and 1989, several well-designed controlled studies then came out, which were published, which uniformly concluded that intragastric balloons at that time was no more successful in inducing weight loss than diet and behavior modifications alone. So from this, multiple studies came out showing a gastric erosion rate of 26%, gastric ulcers of 14%, small bowel obstructions of 2%, Mallory-Weiss tears 11%, and an esophageal tear, a laceration rate of 1% in these 250,000 patients that had these intragastric balloons placed. So this is what it looks like. But there have been some design studies around the world. Genco had 32 patients in a randomized study, double-blinded study, no complications related to the balloon. The mean operative time, 15 minutes to place these balloons in with 500 cc's of saline and 10 cc's of methylene blue. They're all placed on a 1,000-calorie diet. There were two groups in this study. In Group A, the patients had the balloon and had it removed at 3 months. Group B was the sham or control group, followed by a bib placed in them after 3 months. In Group A, they had a significant weight loss of 43.5 BMI to 38, with a 34% excess body weight loss at 3 months. After the crossover, or when you looked at the sham, there was no significant weight loss in the controlled group, 2.1% weight loss in 3 months. At the crossover, the control group had a significant weight loss of 43.2 BMI to 38.8. So this is a good series showing that weight loss does occur with an intragastric type device. So then they looked at, when these patients had the device, do they need a weight loss operation after? And in this series, 86 patients had a balloon placed in them. At 6 months, their excess body weight loss was 32%. And at 18 months, their weight loss was 35.1% after undergoing a gastric bypass. In another group of patients, 82 had a BMI of 48 after 6 months and a 32% excess body weight loss with the balloon in them, but decided not to have a weight loss surgery. And at 18 months, these patients gained all their weight back. So in this study, it concluded that if you have a balloon placed in, you need some kind of definitive operation after. There was a meta-analysis done of all the bib studies around the world, and it showed that 3,400 patients had the bib. There was a 0.8% obstruction, 0.1% perforation. 2 patients died from perforations, and there was a 4.2% rate of removal at 6 months, but with a 32.1% excess body weight loss at 6 months. So it is still available around the world, except in the United States. The next device I'm going to briefly mention is a device called the Butterfly. It is unfortunately still under clinical trials, and basically it is a space-occupying device. You place it in the stomach, and this cell phone type device opens up, and it makes the patient feel full. The next device is a very intuitive, ingenious device, I think. It's two surgeons from Grand Rapids, Michigan, Dr. Baker and Dr. Foote. Basically, it looks like an upside-down funnel, and it's used like an esophageal stent. It's anchored at the G-junction by some hooks, and it just springs up in the fundus, and it makes the patient feel full. So Dr. Foote presented this data at the Michigan Bariatric meeting about 3 months ago, and in a small pilot study, they had 74% excess body weight loss at 6 months. That is equivocal to a gastric bypass or a sleeve gastrectomy done today. Another device, these endoluminal sleeves, which can be attached to the esophagus or post-pyloric area, basically mimicking Roux-en-Y gastric bypass, basically bypassing the stomach, bypassing the first portion of the duodenum. And in a pilot study with this endoluminal sleeve, Chris Thompson demonstrated a 40% excess body weight loss in about 3 months, probably equivalent to adjustable gastric banding. Another device, a duodenal bypass sleeve, the Endobarrier, basically is a post-pyloric anchoring system, mimics probably the gastric bypass portion without the pouch. Basically, it is endoscopically deployed into the small bowel right past the pylorus and anchored in place. First human trial that was completed showed 12 patients enrolled. 10 patients were able to keep the sleeve in place for approximately 12 weeks. 2 patients had it explanted, and at the excess body weight loss in 10 patients after 12 weeks was 23%. So not great weight loss, but it's an endoluminal, incisionless, non-invasive way to maybe make these patients with the low BMIs get down to a point where maybe their type 2 diabetes will go away. Another retrospective study, multi-center study looking at the Endobarrier, 12-week study, once again, prospective randomized study, 25 patients, 14 were in the control group, 13 were in the Endobarrier group. 20 patients, or 80% of subjects, maintained the Endobarrier without significant adverse events for 12 weeks, and the average weight loss compared to the control was 22% excess body weight loss at 12 weeks versus 5% for the control group, which was a good result for this procedure. Actually, I'm going to go back one slide. So actually, at this meeting at SAGES, the Santiago Horgan group is going to present a one-year study on 10 patients with the Endobarrier in place. And at 1 year, they tried to enroll 13 patients. 10 patients had the sleeve retained, and the excess body weight loss at 1 year with the Endobarrier was 54%. And that's talk S047 if you're interested in that presentation. Another device, the transoral Gastroplasty device, basically mimics a vertical banded gastroplasty. It creates a gastroplasty-like lumen here, so patients have early satiety and a feeling of fullness. Some studies have been presented. Here's a study by Dr. Devier, 21 patients treated. 3 months, patient had an average weight loss of about 25 pounds for 20% excess body weight loss, and at 6 months, 26 pounds and about 25% excess body weight loss. He followed up this study at the IFSO meeting this past year in Long Beach, California, where he had 67 patients that he enrolled, and at 6 months, he had about a 45% excess body weight loss. Another novel idea is maybe we can endoluminally suture something to mimic a sleeve gastrectomy. With the big advent of sleeve gastrectomies coming into the field now, a lot of surgeons have tried to recreate this in a endoscopic fashion. Here's Dr. Fogel's data, basically using an EndoCinch device. He had 64 patients enrolled in this study. The average time was 45 minutes, much like an average laparoscopic sleeve gastrectomy. At 6 months, he had about 40% excess body weight loss, much like an adjustable gastric band weight loss. And at 12 months, in 59 patients, which is pretty good follow-up from the 64 patients, he had a 58% excess body weight loss, which I think is pretty good for an endoluminal procedure. And the last procedure I'm going to talk about is called the TRIM trial, basically using the Restore Suturing System by Bard. Once again, it mimics an endoluminal or a laparoscopic or open sleeve gastrectomy, basically by plicating the stomach in from both sides to create a sleeve-like pouch here. So in this study by Dr. Brethauer and Dr. Chan, who's our next speaker, 18 patients with an average BMI of 30 to 45, on average 4 to 8 plications were placed, an average 6 per patient. The average procedure time was a little bit longer, about 125 minutes. No serious or significant procedure-related complication, but the weight loss data is pending, but on average in this trial, the weight loss is probably going to come out to about 15 to 20% excess body weight loss. So this is what it looks like on the inside. You can see as they start here, it's a pretty wide open lumen. As the sutures are placed, the lumen gets smaller, and at the very end, you know, if you scope this patient, if you do a lot of endoscopy after your weight loss operations, this looks like almost like a gastric bypass pouch or even a sleeve gastrectomy pouch. So the question is going to remain, is it durable for 10 years? You know, these studies are early in their phases, but I think once again, there is a big population in the world that have a low BMI with type 2 diabetes, and these patients probably should have something done for their type 2 diabetes, maybe not an invasive or a laparoscopic gastric bypass or a laparoscopic sleeve or adjustable banding, but something in this nature might be more beneficial for them. And in conclusion, I just want to say that if you're doing weight loss surgery, you should be doing endoscopy. I think there is a lot of promise for a primary bariatric endoluminal procedure in the near future. And I think endoluminal procedures can make hard operations safer and easier for us in the future. Thank you very much.